So this could be somewhat embarrassing or interesting, depending. I tried to figure out your languages or your main languages yesterday and Googled them and put something down that sounded like welcome. I have no idea if I'm right or not on most of those, but I've tried. So take it in that spirit, you know, if there's something that's completely offensive on there, I don't mean it. So there's really, I don't know what Pat and Karen talked to you about this morning, but really this course is, this is something of an experiment. I think we've done it now, we're doing it now for the third time, but really what we're trying to do here is to bring a group of people together that essentially teaches each other. We have a training program here, and we have obviously this curriculum, but in addition to that, really the most important thing is that we want you guys to talk to each other. That's the number one thing. That's why we're trying to house you guys together and have, you know, evening things and so on. What we're doing here is we are bringing together diagnostics developers, both from developed and developing countries, both from academic groups and from industry, and bring them together with diagnostics users in low resource settings. And I guess you guys know that from yourself, obviously. We would consider you all sort of diagnostics power users, people who really understand diagnostics on a fairly deep level and are part of, for example, clinical trials and sort of from a somewhat higher perspective. And so what we want you to do, because you really are, all of you guys are experts. You're not, obviously not students, you're experts here. So we would like you to tell us about your diagnostics projects. We would like you to tell each other at this course about your projects, what works for you, what doesn't, where do you need help, do you need funding, technical assistance, you might need samples from somewhere. Also, we would very much encourage you, especially those from low resource settings, to talk to the developers from high resource settings about what's really going on in your countries, what you need, what diagnostics work and which kinds would never work, or how they would have to be modified so that they just might work. So these are the kinds of things we'd want you to do. And in addition to that, I think we want to hear about if you're involved in lab and field validations of assays. We're very interested. One of the things that came out of last year's courses and the one before was that we established quite a few relationships and projects that followed this course. Some people went on to submit their own grants with us or through our center and got funded. Other people ended up working with us in tech transfer projects and so on. So we just want to hear about it, and we want you to talk to us about it. This talk, the bad news first. This is a long presentation, so I'm very sorry about that. I was asked to combine two presentations into one, and I've asked to speak for close to 90 minutes. So sorry. My apologize, and brace yourself. It's going to be a while, and it's going to be a bit slow. And there's a lot of topics that we're going to cover. First, I'm going to talk just very briefly about just the status of global health and what we understand by the term. Then about what does PATH do? As you know, PATH is the lead organization within the Center for Point-of-Care Diagnostics for Global Health, the center that organizes this course. And we'd like to tell you a little bit about this organization. It's one of the several high-profile global health organizations within Seattle. Seattle is sort of a hub for global health, as you probably know. And we'll tell you about that. Then I want to talk about point-of-care diagnostics, both in the developed as well as the developing world. Because point-of-care diagnostics is really used quite differently. Even the term is used differently in both settings. And also, I think the consequences for implementation of point-of-care diagnostics is different in developing and in developed countries. So I'm going to talk, some of this may address only sort of part of your interests, but just bear with me on that. Then I'd like to talk about some what I consider transformational opportunities that point-of-care diagnostics can provide. And again, some from developing countries, some from developed countries, and some that could apply to both. Something about the PATH approach to diagnostic development, essentially our product development process, how we go about finding projects, how we conduct them, how we introduce them, how we get products out into the field, how we partner, that sort of thing. Then the 4 critical elements of diagnostics development from our perspective. Also then, what should an ideal diagnostic look like? And I'm talking here, my talk is not specific to any particular disease. I'm talking very generally about the kinds of devices, the kinds of platforms that we think make sense. I'm going to talk about those. I'm going to give you 3 examples from our current portfolio. There'll probably be a few later in other talks. Then something about the center. So what does the DX Center do other than holding this course? What are the other activities within it? And how can you get involved? How can you access funding, for example, from the center and enter other courses? Then something about achieving impact with point-of-care diagnostics. We have realized a long time ago that, as have many others, that developing a great new technology by itself is not going to do anything. It's very critical to not only develop something, but also make sure that it fits a particular need and that it then gets introduced, taken up, sustained in the long term, funded, paid for by somebody, used the right way, all these kinds of things. So I'm going to talk a little bit about that. Ultimately, I want to, again, pose the question after this talk and in the coming days, what we can do for you. So again, we want to hear what your perspective is. And by the way, I'm fine with, if you have any questions, you can just interrupt me. Also, there's a chance for questions at the end, but please feel free if you want to know something I can answer. So first, the global health, and you may have seen this Gapminder graph before. This is really the 2 axes here, life expectancy and children per woman, are sort of 2 proxies for health, status of health of a population in general. And what I've put up here are the countries where PATH has an office. This is fairly arbitrary, because I just wanted to keep the numbers of dots a little bit smaller. So I put up the countries where we have an office and the years that PATH has been in existence. So what you see here is the 1977. That's when PATH was founded. And so when we start this here, just watch where the dots go. So you can sort of see a general improvement of health status towards the left as the years go forward. We're now year 80, 88, 89. And then something happens, and you can see that, and you can probably guess what happened. So something really bad happens to a few countries here, to quite a few countries. And they sort of come back up a little bit towards the end. Let's run this again. So you see a lot of countries doing just fine, doing better, getting better and better. And then what happens? Of course, HIV hits. So that's really what's happening, and that's what caused a huge impact of especially in sub-Saharan Africa, of life expectancy going down significantly. And this is 2004. Unfortunately, I couldn't run this to 2009, and thankfully, these dots are now actually moving back up. So as with the advent of retroviral drug therapy and better transmission control and so on, there's signs of hope that unfortunately I didn't capture here. So this is still, but it's clearly there's as you all know, there's a lot of need for more work here. In addition to that, health equity, which is what we see is on this previous graph, we saw that health is getting clearly better for quite a few countries, but not in general. And so what's happening here, that can be also expressed here in health equities. For example, life expectancy is actually decreasing in 16 countries, even now. The infant mortality is 10 times worse in developing countries than it is in developed countries on average. Even though nutritional issues have been addressed in many countries, especially in Asia, under 5 mortality is still very significant, looking from 1955 to 2000 and projected out to 2025. But there's still 27% of all infants are born underweight at this point. So that's still even though maybe on overall the health picture is improving, health equity has not significantly improved. So global health, I guess the total picture is it is getting better, but only for some. And that's really what I think has started this fairly significant movement of global health-related activities that we especially see here coming out of Seattle from organizations such as the Gates Foundation, and then programs such as the PEPFAR program and other organizations that are here and worldwide, of course, that are trying to do something about all this. What does PATH do? So PATH stands for the Program for Appropriate Technology in Health. We've been around for a while, founded in 1977. We have a focus to develop technology specifically for low resource settings. I'm going to tell you a little bit more about what kinds of technologies we're talking about. We have over 800 staff now in Seattle and 20 country offices, and we have about a 300 million budget or so. Almost all of it goes, practically, the vast majority of it goes back into projects. So of course there's some overhead, but for the most part it goes back out. We are a private nonprofit organization. We are not affiliated with any other university or government organization or such, but we have ties to all these organizations. For example, several of us are also faculty here at the University of Washington, so we have ties to the university and several active researchers, but in addition, but we are an independent organization. And so if you just looked at it in the simplest possible terms, what is our role? So if you look at developing a technology, any technology, it could be diagnostic, but it could be really anything. There's a certain, for a company to engage in any kind of project to develop something, there has to be some return. And in order to, so the returns are sort of plotted on the right, on the bottom to the right. And that has to be weighed by any organization developing anything against the development risk. And so a company wants to be kind of ideally in the lower right corner here. Almost no risk, lots of returns. You know, obviously there's a lot of competition in this area. Everybody wants to do that. But the reality is most companies are going to be sort of somewhere along that red line, but just to the right of it. That's where normal product development happens. Most products that we develop at PATH are on the other side, where the development risk is really higher than the potential returns. That's why an organization such as ours, a nonprofit organization, has to get involved. And what we're ultimately about is to reduce risk for our partners, for our development partners, so that they can then start taking on development projects that they would not normally consider. So diagnostics companies, they would say, I could develop a diagnostic for TB, or I could develop something, for TB, or I could develop something for cholesterol. Well, cholesterol seems a bit safer. The reimbursement is safer. You have a clear market and so on. TB, I don't know. But what we can do is we can help them in that process and make it attractive for them that they can actually go after the TB project instead of cholesterol. And that's kind of what PATH does. So here you can see that what we create are these product development partnerships, or PDPs. You may have heard that term before. And we create those PDPs to benefit the public, ultimately. So PATH develops a variety of different technologies from what we call the command and control interventions, such as vaccines, which is really something that generally, for example, ministries of health would prescribe and operate, to something that are provider-directed interventions, such as most diagnostics. So those are things that a doctor or a health worker could prescribe and implement. And then even consumer-directed interventions, such as things like condoms or a safe water project, safe water on a household level. So that's things that a consumer or an individual can control and decide on doing. And we're active in all these areas, the biggest ones probably being vaccine development at this point. Diagnostics is a somewhat smaller group, but we're still fairly active in this area. And then there's a whole range of contraceptive technologies of all kinds that PATH is working on as well. So when you think of a diagnostics lab in general, most people, even people in developing countries, probably think of something kind of like this. Ultimately you have some kind of trained laboratory technician with, who are trained to do certain procedures. You have access to certain reagents, machinery, and so on. In reality, however, diagnostics happens in these places too. So while this picture I just showed here, this is actually also taken, I think this was in, I think it was in Brazil, but I'm not 100% sure. But it's definitely not, it wasn't the highest possible research setting. It was just a sort of a laboratory in a clinic somewhere. But and you will find settings like this, obviously, in developing countries as well. There's in almost any developing country, you will find central labs, and you guys might be from those labs because you might be from the sort of highest tier levels of your institutions. So you may well have access to just labs just like those. But diagnostics happens frequently in much less developed settings, such as the ones down here. So top left is just a marketplace kind of setting. Top right is a very, very basic lab in Delhi, near Delhi. And then on the bottom, you see on the right side, this is a screening campaign that is actually very well organized, but still you can only do limited amounts of diagnostics in an open air setting such as that. So I want to go through some of the issues you might face with diagnostics in developing countries, and about half of you know all about this, the other half don't, so that's why I'm still going to talk about this. But some of the obvious issues are there may be access to electricity, but it may be spotty. Instruments, for example, you don't want to introduce a PCR machine that runs for 2 hours if you can't guarantee that the power is actually going to stay on for 2 hours. So you got to do something about that. You might have just simple things like backup power generation or something, but at least it's something to consider. Same thing, access to clean or deionized water and reagents. You can probably do that in a primary healthcare center in most places, but in secondary and tertiary centers, you might not be able to do that. Dust contamination in most labs that I've seen, in some, at least in the secondary and tertiary labs, there was frequently, things got dusty and clogged up, and the instruments stopped working after some time. So especially the more complex instruments, and that's something that we see all the time, is that instruments get donated or purchased, and then they kind of stop working at some point, and there's no backup support with spare parts and so on. So that's something that's very common. Here another one is, this is a picture of lab supplies being ferried around, and this is not untypical. I mean, while it might not be a bike, it might be a truck or something, but it's probably not a refrigerated truck that transports your supplies around, which means that, so you essentially have a lack of cold chain in many places. So there's things we can do about these constructively, and that's really what we're all about. For example, this is a simple example, cold chain. If you don't have refrigeration throughout your transport process, then we need, in almost all diagnostics that we develop, we need to put bioreagents in dry form. So liquid bioreagents will not survive the conditions in most places. So almost all of them are dried, dehydrated, or freeze-dried, or in some form put down in dry form that then get resuspended. Then they can handle it. In blood testing campaigns, while you may have excellent organization here, these may be very highly trained people. But there's just by nature of the way this is being set up, you have a very, very short turnaround time. You need to be able to supply an answer very quickly, because people are going to move through this chain here and move out, and you have to catch them and give them a diagnosis and ideally a therapy before they leave the place. So only certain kinds of diagnostics fit that bill. In addition to that, sampling may be sort of limited because you have to either do it in the open air or behind a curtain somewhere, so you can only do certain types of sampling. And again, cold chain is another issue. So at this point, I want to take a little detour and tell you a bit sort of more on a wider scope about point-of-care testing. No, not entirely specifically about point-of-care testing in developing countries, But we believe within this center, and actually I should mention that this center is part of a network of centers of 3 other centers that all focus on point-of-care diagnostics in different areas. So we have 3 other centers. One center focus on actually health disparities within the United States. As you may know, the United States healthcare system is not uniform across the different populations, and it doesn't have uniform access. So you may find in some areas, such as right next door here at the University of Washington Medical Center, truly excellent and very expensive, high-quality healthcare. In other places, there maybe even within Seattle, you'll find places where good healthcare is hard to come by. So one of the other centers focuses on these health disparities within the United States and how they can be addressed with point-of-care diagnostics. A second other center focuses on emergency medicine. So how can point-of-care diagnostics be used in disaster settings, such as earthquakes, floods, some kind of war situation, things like that. It's a little different from what we are doing because it doesn't need to be as sustainable. You may be able to spend a little bit more money on this because it's a relatively short-term issue, but it's still something where only certain kinds of diagnostics can be used. And then a third center, which is quite different, focuses on trauma issues. So point-of-care diagnostics that make sense because they address the because some diagnostics need to happen very, very, very rapidly, so that you can still make a difference, such as head trauma and things like that. You need to be able to diagnose what kind of medication you should give, depending on what kind of blood clot you might have in what place and such. So let's first go to how point-of-care diagnostics is used in developed countries. Diagnostic testing that is performed, it's defined as diagnostic testing that is performed near or at the site of the patient care with the result leading to a possible change in the care of patient. The key objective is to generate a result quickly to influence treatment. Point of care is designed as an adjunct to central lab testing, not as a replacement. So here you'll have central labs, there are several in this town, there's hundreds across the country, and they are really the core of diagnostic testing. Almost all diagnostic testing is done with big machines, assembly line type operations, and point-of-care testing is sort of almost like an afterthought. You do it because for some specific niche applications, it's the right thing to do. And I think because of as a consequence of the way the system is set up here, with very few exceptions, and there's really only one true exception, point of care has not yet been transformational for many patients or caregivers. A patient doesn't ultimately care where the test happens. It happens, you get a result back, you get a phone call or something, and for the most part, it doesn't change a patient's life if you implement a few point of care diagnostic tests. One example, obvious difference is glucose testing. For diabetics, it does make a huge difference if you can do it in your home as opposed to not at all or in a hospital. But I want to talk about what I consider 5 transformational opportunities that are there for point-of-care testing. First one is this, what I mentioned before, this trauma emergency medical EMT point-of-care suite. So this is an area where speed is really what it's all about. This is where you need just the answer you need ideally in 5 minutes, because the patient dies or is in a coma or something terrible happens. You can get a quick answer. You can intervene if you do it right away. And for example, if somebody has a brain aneurysm or some kind of a clot, if you give the right medication, you can save the patient. If you do it wrong, the patient dies. So that's like the most immediate, very short-term impact of point-of-care testing. That could never be done with a central lab. And that is where, that is one opportunity where really point-of-care testing can transform a patient's life. I mean, it essentially keeps somebody alive versus somebody dies. And that's one of the centers. And here, the kinds of things that are being done here is essentially is to come up with sort of a stat lab in a box for EMTs. And there are significant hurdles, but they seem somewhat surmountable, because here This is a high-tech environment. You're already paying for the ambulance. You're paying for quite a substantial medical infrastructure. So adding an instrument that costs maybe $50,000 is something that's in this setting probably possible. So here this improves outcomes simply because of the speed of the point-of-care test result. A second opportunity is tests that bridge the health access gap. And here the idea is really to find out both why disadvantaged people in the US do not get healthcare access or not proper healthcare access, and then to find out what could be done differently. So in the US, this is a lot of the times it's poor people with less access to information. I mean, some of it is financial, but it's frequently not just financial. It's just simply people don't have access to the right information. They don't know where to go. They may be homeless people. They may be people who are drug users. They need additional support of some kind or another. And what point-of-care diagnostics might allow you to do in settings like this is to go back to what a doctor used to do in a country like this, is to make house calls. A doctor will go to a home, do maybe some testing or at least some syndromic diagnosis, prescribe a medication right then and there. And that's the kind of approach that I think could be transformational also for bridging this access gap in developed countries. This is really something that could be implemented almost immediately. It's more of a matter of political will and also of understanding the system's impact and the relative cost benefits of a process like this. The third opportunity is what I mentioned before, this disaster lab in a box. So this is there's a certain amount of overlap between the areas of biodefense and disaster medicine. This is really infectious disease diagnostics for first responders. Infectious disease is not something that normally gets addressed by a first responder, but in an emergency setting, in an earthquake or something like that, you only have first responders. So you need somebody who could actually address this right then and there. And this is something that's going to take some time to develop. It's a complicated, hard problem. But again, it's a little bit easier than what we are facing in developing countries because at least there's a certain amount of funding available for projects like this. There's another one that's maybe the most out there, outlandish opportunity, but it will, I think, over the long term, 50 to 100 years, will completely transform the way we do medicine. And that is this universal home care interface. So if you visualize, diagnostics that's being done now is all very reactive. So somebody comes to the doctor with a symptom of some kind, and you test, and you're looking for a particular pathogen. If you don't find it, you tend to give up, or you may give some kind of generic medication. That's generally how healthcare is practiced at this point. It's not. We don't have a dashboard of a person. We don't have the little plug-in that newer cars have, where you have a full diagnostic of all the various sensors in your car, and that tells you what's wrong with your car. We don't have that for people. We could have it, potentially. We could have it in 50 to 100 years, maybe in 20 years. And that is something, if we could detect, say, 300 different biomarkers that are prognostic for some kind of condition, anything from chronic diseases, heart disease, to infectious diseases, inflammation responses, this and that, a million different things, patterns of these biomarkers can actually be hugely informative. We don't know yet if this is truly going to work out because we've never done this. Nobody has ever tried to systematically measure hundreds of biomarkers for thousands or millions of people and really sort of figured out the overall large trends of how these things might be predictive. But ultimately, if you could imagine having something like this, you could predict long ahead of actual diseases occurring what's going to happen. And I think there's sort of two sort of grand, I guess, visions of what one could do to improve people's health. One of them is to completely understand the system and completely predict what everybody's going to have over time with genomics and everything else. The other one is, that's quite different, is to say, no, we're never going to know everything about a person, but what we could do is we could boost a person's own defense systems. And I think in reality, it's probably going to be a combination of both. But those two things together, I think, will really totally change the way we practice medicine over the next 50 years. Short term, I think we can pretty much forget about that, but it's going to be interesting. So back to point-of-care diagnostics for global health, though, because there is a transformational opportunity here as well. And I think the interesting thing is, and I really would like to get some feedback from those of you who work in developing countries in the healthcare system. In some countries, or in quite a few countries that we're working in, and that I've been in myself, what is frequently the case is that there may be a capital city reference laboratory that's quite good and of high quality with access to a lot of different technologies, but those technologies are really only accessible to a very, very small portion of the population. Then there are almost non-existent or very minimal diagnostic services in the periphery. And so if you were to now establish a healthcare system that takes care of the complete population, you have kind of two ways to go. One of them is to establish the infrastructure, everything from roads to shipping systems to decentralized healthcare systems, central labs in various places, ways to access people and so on. So that's one approach, is that would be essentially copying our current system, the US current system or the European current system. And the alternative to that is to forget about the centralization and trying to do everything in a decentralized way. And we think that with point-of-care testing, you could actually do this. You might be able to completely bypass this whole central laboratory infrastructure and really build a whole healthcare system based on point-of-care testing. And I think the best analogy for that is this wireless phone versus landlines. In many countries, landlines never were built, because, or at least not on a large scale, because now everybody has a wireless phone and you only need a few cell phone towers and everybody can use them and talk to everybody else. So there's probably plenty of places where landlines will never be built because that's just no longer needed. And I could imagine that point-of-care testing could be a little bit like in that role of a cell phone versus the landline system of a large laboratory infrastructure. So the questions would be, can that sort of be, as opposed to, can central labs become the niche and adjunct system to the point-of-care testing rather than the other way around? You'll always need some kind of reference lab, simply for teaching purposes and research and so on. But maybe you could have maybe only one or two of those in a country, and the majority of testing would be done by point-of-care. There's some real issues with that. I'm not saying this is going to be easier. It's even necessarily doable, for simple reasons. If you compare phone lines and diagnostics in characteristics, I mean, biosamples are not as easy to handle as electrons. I mean, it's easier to build phones that are sort of that interoperable, even if they're made by different companies and so on. But they ultimately all use the same kinds of basic electronics. Biosamples are more complicated, and they're different from person to person. The viscosity changes, the background, components and so on change, and all of these things need to be able to handle those in devices, and also quality assurance, quality control. Point-of-care testing is something that ultimately a person's health or life depends on. If a phone falls out, it doesn't work, it's not that big a deal. So it's something that the only way you could make something like this work is you can make it decentralized, but you still have to have quality systems that make sure that point-of-care testing work on even in a very decentralized area. So here are some sort of challenges and advantages that I see right now for point-of-care testing in developing countries. Challenges are they tend to have higher per test cost in most cases. There's this quality control risk that I mentioned. Sometimes it's difficult to have trained people available especially in outlying areas, because as soon as somebody's trained, they might be able to find a better job somewhere in a more preferred place of living. So and you need a certain amount of training even to run point-of-care testing. Even with point-of-care testing, you still have to procure and distribute the tests. They need to get out there somewhere, even though, so it's not quite like a cell phone. You need to physically get out supplies and cartridges or whatever you need. There's limits to of performance too. In a big machine with lots of calibration and so on, you can probably get a better result ultimately than from a point-of-care test. We like to think that we can approach that quality with point-of-care testing, but it's not always possible. We think that telemedicine can be a supplement to point-of-care testing. So if you have somebody with a picture cell phone taking pictures of some rash or something, you can ask somebody off-site to review that, and that's helpful, I think. But it's also, to some degree, a bit disempowering for local people. So I think ultimately you want the local people to be trained to really make the diagnosis themselves, as opposed to just send it off and ask somebody in the capital city. And sometimes really central lab is really the only possible solution, because there's no point-of-care test available for something. For some of the more complex tests, even things like HIV viral load, like you heard before, there is very little, if anything, available right now that you could use in a point-of-care setting. In some years, I think that'll change, but right now, it's not available. Advantages of having such a system is lower startup cost. It's much easier to distribute individual point-of-care tests than to set up a central lab. It's at least, so you have something right, you can address some populations right away. It's a more flexible innovation. You can do certain kinds of throughputs in some areas, sort of instruments that have a somewhat higher throughput in sort of peri-urban areas, and things that, devices that have a very low throughput or are just one-up tests in outlying areas. It's very flexible. It can be customizable even for regions. You can have a specific kind of test that is particularly prevalent in a particular area, or for a strain that only occurs in some areas and not in others. It's easy to adjust that. There's minimal infrastructure necessary. Tests generally in point-of-care testing are very rapid, so treatment can start right away. And sometimes point-of-care is really the only solution, because if you need an answer on a test within, say, 2 or 3 days, but the transport and logistics takes you certainly several days, but sometimes weeks. I mean, with TB, we know what the average time is to get a result at this point, and it tends to be between 60 and 90 days, even though the actual test doesn't take as long. It would be hugely beneficial to have that answer earlier. And so point of care is really the better choice there. So PATH has, again, if you guys have any questions now, just ask me now or anytime in between. I'll just keep going, but feel free to interrupt me. So how do we go about developing diagnostics for low-resource settings? We think that ultimately, in order for something to be sustainable, there need to be the right incentives for everybody. And so that practically means somebody needs to be able to profitably sell something and get a salary and all that sort of thing that we all like to have. And so we would like to make whatever we develop, when we work with our partners, we never ask them to make a loss. We try to make it possible for them that they can make a small profit so that they can keep making it and that they're interested in making it. So having said that, so we believe in some sense in the market here that the market, that there needs to be some market forces that drive this. But at the same time, market forces are clearly not alone in ensuring diagnostics availability, because otherwise they would already be there. They're not in most places, and there's probably not much market interest in developing diagnostics for neglected tropical diseases, for example. If you look at some of those neglected tropical diseases with maybe a market demand of maybe 100,000 tests a year, and you as a company has a choice of making one of those for a country that probably can only pay you $1 or $2 per test, or you have a choice of making something else that's much more profitable, you're not going to do it, even if it were easy to do it. And so there need to be other incentives to do this, and that's why I think that's some of our approaches that we use here. Also, we are very, very user-centered, so we would never start developing something in our labs without talking to ultimately to end users, everything from healthcare workers to patients to Ministry of Health and so on, because there's no point in developing a technology if it's not being taken up from our perspective. So we do user needs assessments, and you'll hear more about this in the class. But the general idea is that we use fairly elaborate processes to find out what really is needed, and then we assemble that information and put it together in documents such as market requirements documents, product requirements documents, and product specifications, even before we ever develop anything internally. And also we believe that one size does not fit all. So this gets us in trouble sometimes with the Gates Foundation, because they tend to like sort of silver bullet solutions where you develop one great gadget and that's going to solve all the problems in the world. We kind of been there and tried a few of those, and they didn't really work. So we say, there's a lot of different solutions, a lot of different people come up with solutions, and even if we have something that we think is really cool, it's probably going to only address a small portion of the real problem. So we understand, we accept that reality and work one piece at a time, really. So as I said before, we remove risks for all partners. This means we remove technical risks by doing R&D, tech transfer, and support. We remove market risks by doing these user needs assessments. That means, for example, if a company wants to engage in a particular area, at least they know what they should produce, and likely how many of whatever they're producing they can sell in what time. So we can make it a little bit easier for them. We can remove clinical risks by helping with lab and field validations, and we also help with uptake risk, and that's probably one of the biggest areas that is usually needed. Even if you have something that's perfectly fine, it's validated, it's a good test, a lot of these still die at some point and don't go any further. Or even if they are taken up in some small project, they may not be able to be sustained. So we talk to the opinion leaders and the health ministries and involve them at an early stage and do essentially the equivalent of lobbying and just trying to find out what is it going to take to really take this up on a larger scale and keep pushing, keep advocating all these things until ultimately a test is sort of mainstream and then it can sustain itself. So all these things result in viable, low-resource diagnostics products with lower product profit margins that companies may be comfortable with, but they are comfortable enough with them that they actually produce them. So we are generally about public-private partnerships. We have a multidisciplinary team-based approach. That means we have in every product team that we develop, we have a field person, somebody who knows about the settings, the conditions in the field, a market person, some MBA type or some commercialization expert, and a technical person, and they are sort of equivalent. So we are not just technology-driven, we have a team approach for that. We work within the product cycle model, such as, generally the industry works as well. It means that we develop something and then we work on improvements over time and understand that products will not last forever and will be replaced after something else comes along that's better. And again, we have intimate contact with the field through our over 20 field offices, and we have many people from developing countries working at PATH, of course, and many of us go to developing countries routinely, so we have a fairly good insight, but ultimately, even though we think we understand it pretty well, whenever we really try something new, we need to go all the way back to the field and learn from there what we can learn. So these are the four critical elements: understanding the needs of the vulnerable and at-risk population, creating the right incentives, I mentioned that before, build the evidence base for informed decision making. So what that means is we might go with an economic analysis to a Minister of Health, and tell them, if you invest 70 cents per person on this particular test for this group of people, you will save yourself this much later because of reduced, more ability to work and so on. And so very, very sort of kind of hard-nosed, not very altruistic really motives, but it's very sort of economically driven things that can convince governments that this is worthwhile doing. And that's really what we mean by evidence-based. Evidence both on a clinical sense that the test actually works, but then on a commercial sense, economic sense, if it does work, what does it do? And how does it affect the bottom line of an economy? And then in addition to that, we understand that for tests to be implemented, systems need to be strengthened for delivery, distribution, and use of the test. So user needs: who is at risk? What is the current intervention? How is the intervention delivered? So we look at how do people test now, if they test at all. What is the syndrome? For example, if you do syndromic testing, what's the evidence of this working? What's the evidence of this not working? Maybe in some cases, syndromic diagnosis is perfectly fine. If your medication, your drug, is fairly harmless, you might as well give the drug. What's the downside? That's not a big problem. So maybe there is no need for diagnostic. In other situations, it's very different. If you have a fairly harsh treatment that has a lot of side effects, you really want to test first before you give it, if it can have some real risks. I mean, obviously, you would never give antiretroviral therapy to people who don't have HIV. That would be too much of a risk and too much of a downside. But for other things like malaria, it's fairly routinely done, even though there is a certain amount of downside, but it's not individual. So the problem that's not captured here, and that we are trying to capture as well and demonstrate to the Minister for Health, is things like public health downsides, such as drug resistance. For an individual, getting antimalarial is probably not particularly harmful. Of course, it creates resistance, so over time it'll be more and more expensive and more difficult to treat malaria. So that's something that can all be economically calculated out and projected out, and that's part of what we do. So we usually summarize this by, we need to understand those who use the test, who choose it, and those who pay the dues, and that's in most places 3 different people. Even in developed countries, it's rare that the patient actually understands what the test is and selects it and then pays for it. It doesn't work that way. It's usually there's 3 different groups. The incentives are not aligned. And so that's something that's a cause for our very bloated and expensive healthcare system, and that's also cause for inefficiencies in other countries. Incentives. So we have to get the commercial sector, the public sector gatekeepers, the people who, for example, allow you to import a test or have it manufactured or have it tested. Then the healthcare providers and the end beneficiaries, they all have to be able to get something out of this. So this could be monetary, this could be a health benefit, this could be some general benefit to the economy, but it needs to there has to be something in it for everybody. We have a sort of a clear, we have a guiding principles for partnering that's published on our website, and that sort of gives general terms for how we get engaged and how we avoid conflicts of interest and things like that. We're very conscious of as we're growing, that once in a while we may get into situations that are difficult, and so we need to understand. We need to be very clear about where we get engaged, how we get engaged, and transparent in how we work. And that's largely published. Evidence, new technologies a lot of the times are disruptive. So to be successful, you must demonstrate a savings or gain in lives in terms of morbidity or mortality, in terms of money, in terms of time or work. It should be quicker or something like that. Or it somehow should give somebody a political or social capital. So sometimes it's even sort of non-tangible things that actually make somebody want to use a test, even if it's not necessarily an immediate benefit, but it might be things like status or something. It might be, in some cases, even if there have been models where people have been very successful in getting very more or less volunteer healthcare workers, and they benefit from having sort of increased social status by that. I mean, we all do that. I mean, we give, free talks at places. So this is related to that sort of psychology. But the fourth thing here is systems. So we need to understand the logistics, the infrastructure, human capital, human organization in the systems for distribution, delivery, and use. So That means there's no point in developing a diagnostic if you don't know how to get it to the people who use it, how to keep it in storage, how to sell it, how to charge for it, and all that. So that all needs to be in place. So these are the 4 elements again in summary, and yeah, so I mentioned it already. So now a little bit about what do those diagnostics look like that we develop, or what should they look like? WHO has a model that's called the WHO Assured model, and we have actually one of the people in our board, advisory board, Rosanna Peeling, really was the one who came up with this model. It just states kind of the obvious, but it's a good way of stating it. It needs to be affordable by those at risk of infection or disease in general, needs to be sensitive, needs to be specific, needs to be user-friendly, simple to perform with minimal training. They need to be rapid, robust, enable action at the point of care, equipment-free as much as possible, doesn't always work, but ideally, and deliverable to those who need it. It means they have to be transportable, without cold chain and so on. So that's sort of like the high-level view. So what do we really mean? We do a lot of different diagnostics projects here. I'm not going to go through even most of them. Just wanted to give you an idea for how sort of the kind of breadth of the projects that we have, and I can tell you more about that, or some other people from our lab can tell you more about that tomorrow when you guys come to PATH in the evening. But in general, you can see sort of the classes of things. We work on one microscopy-based project, then a bunch of immunoassays, a bunch of molecular assays. So the purple ones are the immuno, the pink ones are the molecular, then there's a few cytometry-based ones, and a bunch that are sort of cross-platform. So different platforms, but ranging from very simple to fairly complex. This is really one of the few tests that have made this platform that has made real impact in developing countries. Lateral flow strips, you probably have all seen them. The pregnancy test strips, they look like pregnancy test strips, and they're available for a bunch of different diseases. And what we really like about them is the simplicity, and really they're almost irreducible at this point in terms of complexity. I mean, they contain everything you need to have for sample prep, for fluid movement, for signal visualization. You have a control built in, you have a bio-waste containment, and the whole thing costs about 25% to produce, and most of them are sold for in the neighborhood of 60 cents to $1 or so in developing countries. Of course, in this country, if you buy one, it costs you $15 or so, but that's different. Somebody makes some money there. But I think the main reason I'm showing this one is because it's something, whenever we develop a new platform for diagnostics, or we work with somebody who proposes a platform, we kind of suggest to look back at this one and say, is there a way we can make it kind of like this, as opposed to the great new thing with the chip and this and that in there. Do we really need all these things, or could we kind of make it more like this? And so that's kind of the motivation. And also, they've been successful. These are some of the ones we have transferred over the years, and there's some pretty big sales numbers in the second to last column on the right. And I do want to mention, by the way, we do make absolutely no money off any of those. So this is, even though there are lots of them sold, we get no royalties or anything like that. It all goes back out. So. These are great tests, lateral flow strips, they are all that, but they are not always accurate, sensitive, and specific enough, and they sometimes or frequently cannot detect active infections, for example. So that's why we have to go beyond this format, and the format, there's several formats we're working on, but they're all essentially molecular assay formats, nucleic acid-based assays, that can be a lot more sensitive and specific and so on. So there's a lot of different technologies. Most of those are from us. Some of them are from partners. And I just wanted to show you that actually every single one on this list here was really developed with the purpose of addressing a global health need. Most of those at least the ones that we were not involved in, we like to think, but even some of the ones we were involved in have not undergone the stringent kind of user needs assessments that we now do. And so not all of those things were successful. But I just wanted to show you that there's actually a lot of groups, academic groups, and also companies working on things specifically for developing countries. It's actually a fairly hot field that a lot of, at least researchers, are very interested in. Here are 3 examples of projects, how we work and what we specifically do. Here's one for Chagas disease, a strip test for Chagas disease, then a much more complex HPV screening device, and a strip test as well, and then some technologies to develop an infant HIV test. So first, Chagas testing. The need is significant. This is a disease primarily or exclusively in Central and South America. There's 12 million infected, 90 million are at risk, but it's definitely a disease of rural poverty. So because the way the vector occurs in rural settings, at the edge of the forest. And so the kinds of people who have it tend to be very poor people who don't have access to capital, don't get to capital cities much. And if it left untreated, it causes chronic debilitation and early death. The opportunity is fairly clear here. There is a drug that does exist. It has significant side effects. There is, I'm saying here, no low-cost point-of-care tests. There are some point-of-care tests, some strip tests, but they really haven't been widely distributed. And some of them work, they work somewhat, but may not work in all places. But there's clearly, so we found clearly a need for another better, more sensitive strip test to address this. And what we did was we partnered with a company out of Argentina that actually makes a good ELISA assay. So they have a very good, very sensitive ELISA assay for Chagas. Problem is, ELISAs you can't run in the field, so you need to create a strip test out of this. This company didn't know how to make strip tests. We knew how to make strip tests, so we worked with them. We took their chemistry, we converted them into a strip test, and so this is the strip test that was developed. It provides rapid results in about 30 minutes with a sensitivity of 99.5%, specificity also pretty good, no equipment needed, fairly low cost. And so really what this all means is this is not a complicated project. This is something, there's not a lot of, you might get a paper or 2 out of this, but this is not, for a scientist, this might not be the most earth-shattering new thing because people know how to make strip tests and so on. But this is the kind of stuff that we do because I think we believe it's really impactful. It's gonna allow people to do one main test and a confirmatory test in a field setting and start treatment right away. And we did this in a way that will not significantly increase the cost of the process. So we are right now pretty much done with the clinical validation in laboratory. We have a bit more R&D to do, and then we're going to move on hopefully with availability in late 2011 or 2012. So this is a very different project here. This was actually, I just want to mention this because this is one kind of project we do. This is not an I mean, it's expensive, but it's not anywhere. I mean, this would be something that we would do for a few $100,000 or thereabouts. That's what it would cost a funder to do this sort of thing, which is significant, but it's not completely out of reach for most funders. This project here is very different. Yes?
Can you tell us how much does it cost per test?
The test, we don't have a final cost of this one yet, but it's going to be in that, similar cost to the ELISA number. So about between $1 and $2 probably, somewhere in that neighborhood. So this is a very different project, cervical cancer diagnostics. Here we addressed the issue with funding from the Bill and Melinda Gates Foundation on a very large scale. So here what we are doing is we develop with companies screening methods for cervical cancer that are compatible with developing countries. And this is really something that in many developing countries hasn't been done at all, really. I mean, here in developed countries, for the most part, people do pap smear. Pap smear is actually a pretty miserable method, to be honest. It's just, it works because people are asked to come in every year, And so the cumulative sensitivity is actually pretty good because cervical cancer grows relatively slowly, so over time you will catch it. It would be too, in many countries, that process, to implement that from scratch would be very, very difficult to do and ultimately not cost effective. Even though it would improve the lives of some people, it would cost a lot of money for a health system and money that would be sorely needed in a lot of other places as well. So we were looking at ways of doing this that would cost less and would accelerate the screening and would be more compatible with developing countries. And essentially, we came up with kind of two approaches. One of them was in a collaboration with QIAGEN. The other one is in collaboration with an entity called Abavida Corporation. And what you see on the left side actually looks like a fairly standard piece of lab equipment. It's a molecular assay that does tests for the oncogenic strains of HPV. And it's actually an offshoot of a technology that is being in use in developed countries already. And what we did here is really, again, not something that as a scientist, or at least as a device developer, necessarily will get all that excited about. It's sort of improving things around the edges of a technology. So what we did here is we made the device a lot lower cost. We made the chemistry so that it could survive without cold chain. So we used dry chemistry as opposed to liquid chemistry. We made the transfer of reagents easier. And so ultimately, the individual test cost is a lot lower than what it would be with the conventional assay. But it still needs a laboratory. It still needs a certain amount of training and so on. So this is the kind of device that would fit well into a primary and maybe tertiary healthcare setting, but it would not really fit into a tertiary healthcare setting, certainly not field. But it has its value. In addition to that, we worked with a company that had a radical new approach. And that was to be able to detect not HPV, the presence of HPV or the presence of oncogenic HPV, but the ability to detect the likelihood of progression to cervical cancer for people already infected. So this is something that is based on a biomarker that is only present once the cancer develops. And so this is of course a much riskier project, because what you're essentially asking people to do is you're asking people to test, and what you're saying is, yes, you are infected with with HPV, but don't worry about it. You're not going to get cancer. And that's a kind of a difficult sell. So what we have to now show over the next very long time, maybe 10 years, that clinically this is actually a good approach. So for a long time, for some years, this will only be an adjunct test to the other test. It will not be able to stand on its own. But hopefully over time we can demonstrate that this is actually an accurate and sensitive and specific test that can then replace traditional lab testing. So here the way this worked was the partners conducted much of the product development and assembled the intellectual property and so on. And also they are the ones responsible for product registration. And PATH provided product development input, so we helped design them. We provided samples. We did large-scale sample collection studies in India and in China. We conducted user needs assessments, and we developed an evaluation framework for public health programs. The idea here is that this is one kind of partnership. This is a very, very large, expensive kind of partnership. It takes many, many years. We've been at this for now 7 years. The first product is now starting to be available in pilot studies. It has gone already through clinical studies. This was an expensive project. Cost so far probably in the neighborhood of $25 million. Very, very expensive. But the Gates Foundation supported that project for a long time. And so that's one kind of very, very comprehensive project. We think that this is going to have a big impact too, but this is not a quick win. This is something where you have to long work at it to really make it impactful. The third project I wanted to talk about is infant HIV diagnostics. So infant HIV, as you all know, is something where the regular strip tests don't work. They're not sensitive enough. There's not enough immune reaction at that point. Yet, if you could test infants right away, you could do treatment in some cases, and you could certainly start ART, but in some cases, you might even be able to completely avoid infection in the first place. Or at least get rid of it in the first place. So there's a lot of, there's 420,000 known infected infants each year. Most of those die before the age of 2. Right now, the only way you can really test it is with a molecular assay, with a PCR machine. The Roche test right now costs about $21, and the turnaround time is way too slow. Practically, I mean, even though a PCR machine would be quite quick, and you could do the test quickly, but the reality is that it takes 1 to 3 months for an answer to come back. Too late in most cases. So there is also 60% of all infants are lost to follow-up by 6 weeks. So if you haven't gotten an answer back within 6 weeks, people in family might have moved on or just would not be accessible to healthcare anymore. So what are we doing? We are replacing essentially what we have on the left side here. This is the the Roche machine, and it comes with it needs a prep unit. The bottom one is the Roche machine. The top is the QIAcube prep machine. That's the kind of lab equipment you would need to do this right now. And we're trying to replace this with something that kind of looks like a strip with a little heater. And I would be happy to show that thing to you guys when you come to PATH. To at least the prototypes, what we have so far. But essentially what we're saying is we are using an amplification chemistry that can use dirty nucleic acid. So there's a little sample prep involved. It uses a very simple isothermal amplification. So you don't have heat cycling as with PCR. You keep the temperature constant. And in fact, it's a fairly low temperature. It's not very, very hot. It uses low cost and field-friendly material for the disposable. And it uses, we have a version of it that uses actually chemical heating as opposed to an instrument for heating. So it uses an exothermic chemical for heating. And we have developed interchangeable modules for different niches to combine the simplicity of the strip test with the sensitivity of PCR. And here are the modules. So we have things that, I'm not going to go through all of it here, but the general idea is to to come up with a very, very simple sample prep as opposed to having something like a QIAchain kit that needs to be, you have 5 different reagents and you have to spin down the sample and so on. We have developed something that's called a DNA capture card that doesn't require any sample prep, that doesn't require any instrumentation. You just put a drop of blood on it, and then you break off a portion of it and you put it into a vial. And that vial then is the one that gets heated up, and the vial already has the amplification chemistry in it. And that's the amplification chemistry specifically that we're working on are the 2 that are mentioned here, are LAMP and something called recombinase proteinase amplification. A third one that we have, we are evaluating is called XPAR. There's a number of different ones that you may have heard of. And then we combine this with either our this hand warmer, this chemical heating method, or with a small instrument, depending on the niche. And then detection, we either do visually with a strip test, or with just looking at the fluorescence signal, or also with the instrument. So, so this is the circles here represent pathways for how we come up with a non-instrumented approach to nucleic acid testing. So these will be all things that don't require power or anything like that. This is all non-instrumented. But the other ones that have instruments, they would be used in places where you have a higher throughput, so where you can justify paying for an instrument, where it makes more sense to have an instrument. And in some cases, like where you don't want, if you don't want to do HIV, just infant HIV testing, but HIV viral load testing, you need to have a quantitative information, and that right now we couldn't do without an instrument. So for that, you do need an instrument. So back to this transformational opportunity, really, and those questions, I just wanted to put them back out there. I don't have answers for them, but I've shown you a few sort of point-of-care tests and sort of thoughts overall for point-of-care testing and telemedicine leapfrog, developed country-style lab infrastructure, and will they be niche or adjunct systems rather than the norm. I think these are open questions, but I think there is something to be said for doing at least a significant amount of point-of-care testing in developing countries rather than setting up central lab structures. The point-of-care center it consists of 5 different cores, core activities. Core stands for just core activities. And what we do in the center is we do lab and field validation of devices, of diagnostics. We fund exploratory projects. We perform needs assessments, and we perform trainings. You guys here are part of our core 4. So this is, as you've probably heard before, this is the first course in a series of 4 courses that you can qualify for. And we fund those in most cases, and we so the whole, I guess I wanted to, I gave you this in the handouts. I'm not sure if you can actually read this. If you don't, I can send it to you. But this really describes what the center is about. So the whole idea of the center: what is our goal, what is our mission, how do we do it, what are our processes, and so on. I'm not going to go through them. But if you're very interested in this, by all means, have a look at it, and then probably it becomes more clear what we're trying to achieve. But as maybe a shorthand for it, what we ultimately are about is to reduce the barriers to the availability of innovative and affordable point-of-care diagnostics in low-resource settings through rigorous assessment, design, testing, capacity building, and outreach. So this is a fairly lofty goal. Essentially what we're saying is we do whatever it takes in a particular diagnostics area to make those diagnostics cheaper, more available, and so on. And if it takes developing them or inventing them, we do that. If it takes just testing them, we do that. If it takes doing advocacy for them, that's what we do. So we're just sort of trying to fill in that gap. We hardly ever do the whole thing. We just do bits and pieces. So in Core 1, we do these lab and field validations. So what that practically means is we can, so if any of you, for example, have diagnostic tests that are currently at the somewhat advanced prototype stage, you can propose to us that we validate them, and we have a process here to do due diligence and then laboratory validation, field validation for them, and that would happen at no cost to you if essentially it's something we're interested in and we think that is worth doing. So you could get involved here on both sides. You can either be a validation partner in the field as a field validation partner, or you could be somebody who has these tests and wants a place for them to be validated or to get the word out about them and so on. And the way we do it is we do this, we want to make the tests better. So this is not our interest to make a test, to sort of test a new test and then tell the world what a terrible test that is. There's no point to that, in our opinion. So what we want to do is we want to make sure if it's a good test, we'll let the world know. If it's a bad test, we'll let you know and give you a chance to fix it. And we have done that in the past, actually, with previous people, just like you guys, who have proposed tests to us, and some of them were very good and some of them were not so good, and we helped try to make them better, and we're still in the process of doing that. Core 2, what we do is we have these requests for proposals once in a while that are very specific. So they might be something on a sample prep device for sputum preparation or something like that. Then you can, if you have technology that addresses that particular area, you can propose that, and then we can fund it if it's qualifies. This is a competitive process, so we have peer review and so on. But we have the ability to be more flexible than, say, NIH would be. We can be very specific. We can tell you, for example, we like this part, we don't like this other part you proposed, so just change your proposal, and then we would fund it, for example. So we have some flexibility that way. The third thing is, what we are doing is we assess unmet clinical needs for diagnostics. So we have, for example, one project, a large project right now, where we are looking at the possibilities and pitfalls of multiplex diagnostics in developing countries. So there is this ability now, as you probably know from if you're a developer, to develop these kinds of tests in a box, the molecular tests in a box, and you can multiplex them. You can provide answers for, you can test for 5 to 10 different things in a single sample and so on, at least in theory. What's less clear is how would that information be used? Is this actually worth doing? Is there a downside to this? If it's good, how can it be done optimally? And so on. So essentially what we come up with, we ask a lot of people, we ask experts, we ask users, we ask what kinds of diseases would they want to have on them in different settings. And if they had it, how would the information have to be presented so that it's actually useful to people, as opposed to, because it makes little sense if they hear, yeah, you have this disease, but there's nothing I can do about it. So that's an information that needs to be sort of managed to some degree. Then core 4 here, this is all about, I guess capacity building is one part of it, but the other part is increasing partnerships. So what we want out of this whole training program is partnerships between you guys, partnerships between you and us, partnerships between you guys and our partners, and between other developers and so on. So it's all about, learning as much as possible about each other and forming partnerships. And core 5 is the administration of the whole center that provides the infrastructure for the whole thing. This is an image for what has happened in the past here. So these cores are actually quite interconnected. For example, core 4 participants provide feedback to us for unmet clinical needs. Core 3 results inform core 1 validation process. Core 1 fundee might participate in a core 4 training. We have people here who might get involved with us in core 1, for example. We have so there's lots of interactions that are possible. So there's a few things here that we kind of like. I'm just bringing them up here as sort of the next frontiers from a developing assay from a technology point of view. And you'll hear this probably in other presentations later. Paper microfluidics is sort of a new kind of platform. It's kind of cool. You can ask Elaine and some others here in about this. It's maybe a new platform where you could do nucleic acid testing and immunoassays in a much simpler way. We are now quite interested in chronic diseases as well, especially diabetes. As you probably all know, diabetes and chronic diseases in general are just on the verge of overtaking the infectious diseases as a cause of mortality and morbidity in developing countries. So we see a big lack of appropriate devices there, appropriate ways of doing diabetes testing and screening and treatment and so on. It's still largely inaccessible in most places. So we're getting involved there. Multiplex diagnostics, we believe strongly in, although it's technically definitely a challenge. Certainly everything related to HIV, viral load, and CD4 testing in low resource settings, in field settings, we think remains a very, very important goal of ours. So impact. That I told you quite a bit about developing diagnostics, but there's still a gap here somewhere, and I think that's something that we're trying to fill with various funds, but it's for example, we can fund diagnostics validation, testing, needs assessment, outreach, we can do training, but ultimately when it comes down to it, there's a need for somebody to fund pilot projects on the ground to really get these tests out in the field, and so that you can demonstrate to the Ministries of Health or the purchases, even the vertical funding programs such as PEPFAR, you need to at some point demonstrate that this is going to make something more cost effective or better. And that's a part that is still somewhat hard to fund. Most funders are much more interested in the early stage work and much less interested in the downstream work. And so we're trying to change that perception. We are advocating with our funders, but that's something that I think we are all aware of, that is still an existing funding gap. So funding diagnostics is quite expensive, especially if it comes to new diagnostic platforms. I used to work at a company where sort of the standard mantra was whenever somebody asked about what it costs to develop a new diagnostic, when a customer came and they wanted to know how much it would cost, we always said 5 years, $20 million, because it's probably about right. You know, it's always expensive and much more expensive than you think, and that only gets you really to an advanced to a manufacturable prototype, but it doesn't even pay for the marketing and all the other things that you might have to do. So I'm not going to go through great detail through this, but there are some sort of specific funding areas and funding mechanisms that allow you to fund things along that pipeline, and we are accessing those as much as we can. But it is an expensive process, so I want to conclude my talk with a few good arguments to obtain funding, because I think you guys are most of you are researchers in some form or another, and you need funding, and so I'm trying to come up with a few that work. So why does it make sense to develop diagnostic tools specifically for low resource settings? So if you want to make arguments to your boss or your board or your investors, if you're diagnostics developers, you could appeal to their altruism. So this is something that sounds funny, but actually, surprisingly, over the last 10 years, people have changed. The societies have changed somewhat. Actually, not all corporate bosses are hard-nosed individuals. They may actually do something just because it's the right thing to do. You'd be surprised. Sometimes that actually does work. You could make them fearful of all the terrible diseases that are going to come our way, if we don't quickly do something and treat them where they happen. And greed too, because there's two ways they can make money off this. One of them is they can actually make some money off a test for developing countries. If somebody comes up today with a TB test that costs $2, works really well, gives you drug resistance genes and everything else, developing countries are going to pay $2 for a TB test like that. They're going to do this. So if it costs you $1 to make it, you have a giant market. And so that's a huge, gigantic market. Same thing, if somebody comes up with a low-cost diabetes control program, that's going to be a real big market. There's 30 million diabetics in India. Somebody's going to get that market somewhere. And so there's some real money in this for developers. It's just you need a different approach to address that market. But the other way to make money off this is to have benefits that you gain from developing these assays that come back when you sell into developed countries. For example, if you optimize a process or an assay for developing countries, that same assay may come back as a test for home testing in a developed country, and may be perfectly appropriate because it has the same kinds of characteristics. So reverse technology transfer to some degree, I think, is possible. And there are some companies, even among you guys here, some groups that work exactly on that model, where the primary motivation is right now to develop something for developing countries, but the side motivation is to have something that can also be used in developed countries. Arguments for the government or for your funder. With diagnostics, what you're trying to do ultimately is to prevent waste, because you don't want to waste the drugs on the wrong people, essentially. You want to prevent worse problems in the future by you want to test so that you don't cause antibiotic resistance, anti-drug resistance. You want to reduce health system costs overall. 5% of medical expenses are right now spent on diagnostics in developed countries, and that 5% influence 70% of the decision making in medical care. So a little bit of money well spent on diagnostics can influence a lot of cost downstream. And I think it's similar numbers probably you can find for developing countries. And ultimately to improve lives. I mean, that is a motivation in itself. Even though it's economic and so on, but there is value in just that. And unfortunately, there's also good reasons for why not to develop diagnostic tools, specifically for low resource settings, because you have a whole bunch of challenges here. You have to develop a test that works just as well as one for high resource settings, but it costs about 1/20 of a comparable high resource settings assay. You might get $1 for a test as opposed to $20. It has to work in conditions that are much harsher than the sort of nice lab settings that you find here. It has to require very little training. And by the way, you're not going to have as much money for the development process because there's not going to be as much profit in it. So you have to make do with less. So that's all very, very hard. But the good news is it can be done. We have a bunch of examples here, and you'll see them at PATH, where that very process has been successful. These tests have been profitable. They have been impactful. And we think that while these are mostly immunoassays at this point, the similar ones will eventually be doable for molecular tests as well. So I want to end with this slide, the same one I showed before. This is what I'd like you all to consider, is to think about all these things and then tell us from your perspective what you would like us to do. That's really ultimately what we want to hear, and tell each other what you want to get done. All right, thank you.